Yes, hello. For those of you that don't know me, I'm Dr. Jen Unwin. I'm a clinical health psychologist by trade, worked in the NHS for over 32 years, and I've been helping David in his practice to bring some of the psychology of behaviour change and maintaining that change for the last 10 years. And also in the last 2 or 3 years, I've personally been trying to learn everything I can about sugar and food addiction. We had a fantastic day yesterday at the Bristol Royal Marriott on that topic. So anyone who wants to hear more about that can come and find me later. I'll hand over to David.
Yeah. So I'm Dr. David Unwin, a GP from the north of England, and we've been trialling the low carb diet now since 2013 in our practice, and I'm absolutely passionate about treating people with diabetes but not using drugs. And this talk is about some of the things we've learned and how to be more effective in clinical practice. So let's make a start. First point, let's just get some physiology sorted out about insulin. So the hormone insulin can be thought of as pushing glucose, and it's pushing it out of the bloodstream and into cells to reduce blood sugar. In some cells it becomes fat, so that's a kind of basic thing, and it's a basic thing I like all my patients with type 2 diabetes to understand. The second point is you'll hear me talk a lot about hemoglobin A1C. Hemoglobin A1C is the usual thing that doctors measure when we're looking at the sugariness of blood for people with type 2 diabetes. So I encourage my patients to think of a hemoglobin A1C as a measure of how sugary your blood has been for the preceding 3 months. Now I'd like you to meet, this is Dan. This is Dan, and he's really happy for you to see his data. And we're looking here, well, you can see it there. That's a graph of his hemoglobin A1C. And you see where the great big arrow is there. He presented a couple of years ago with a hemoglobin A1C that was sky high. That is really high, 95 millimoles per mole or 10.8%. That's really, really high. And then you can see that it drops like a stone and goes into the normal range in the blue. And what you're seeing is a wonderful thing. This is type 2 diabetes remission, drug-free type 2 diabetes remission. It's a really exciting thing, and there's a big drive. Really, this is very popular now. People are really interested in how do you achieve type 2 diabetes remission. And just look at Dan now. Just look at Dan. And thank you. Dan is so proud because it's changed his life, as you can see. He's not a patient really at all now. He's not ill, he doesn't need me, he's self-caring, and he doesn't have diabetes. And in fact, he doesn't have any other illnesses, and he's not taking any tablets. And so I suppose what Jen and I have learned is about how do you replicate cases like Dan's reliably time after time. And we've actually now, we've got 117 cases of drug-free type 2 diabetes remission in one practice. So it's kind of proof of concept really, because we've done it once and twice and now 117 times, and other GPs all over the UK and all over the world are doing this as well. It's a bit of a messy chart, isn't it? But what I want you to see, if you look in the third column, number of type 2 diabetes cases in remission. In 2017, I'd only got 15, and they'd been on the low carb diet for 13 months. But just spring forward now, I did this a couple of weeks ago, 117, and they've been on the diet for 2.5 years. So very often you're told, oh, low carb, works in the short term, over a few months. But we find in clinical practice it actually works much longer. The longest remission I've got, I think, is 9 years now. So it really does work. Also, just look there. That's the remission rate, the next red column, the remission rate for people who choose the low carb approach. So of the people that choose the low carb approach at Norwood Avenue, 52% of them are going to achieve remission. Well, just think if you had a drug that could do that. It doesn't exist. That's an amazing thing. But then people say, well, that's biased because they've chosen the diet. But actually, I think choosing a diet is fine. And you're more likely to be effective with a diet you choose. But okay, I'll accept there's some bias there. So go to the last column, and then we're looking, ours is a practice of 9 doctors and 9,500 patients. So we've got 22% of the entire diabetic register in remission. That's like a modern miracle. I'd never seen a single case of drug-free diabetes remission in 25 years. In my practice, and I've seen it 117 times. And one thing about evidence is if you can replicate something, so you say n equals 1, well, that's just a story, isn't it? How about n equals 117? Because it seems, and then other GPs all over the country are getting very similar stuff. That's also evidence and has its own quality. So 22% of the entire diabetic register. And if you take people like Dan, and you say, right, today, what should we do about your diabetes? We could start lifelong medication right today. Or are you interested in maybe avoiding drugs? What I find is if you actually take the time to ask people, which I have done, not a single person in 9 years has gone for the drugs. Not one. So people say to me, oh, the general public are not interested in lifestyle approaches. I don't think it's true. I don't think they're given the opportunity. So you need to ask them, are you interested in a lifestyle approach, and offer support. And if you do that, the cumulative effect is we save £68,000 on the diabetes drug budget alone. That's just the diabetes budget. And you can see those are all the local practices, that's nationally collected data. Year after year, the difference between us and the average GPs is getting greater and greater, and it's because of the number of people who are opting to do a lifestyle approach instead of take drugs. I published a paper last year, and we calculated if every GP in England prescribed as we prescribe at Norwood, you would actually save £270 million per year recurring on the drug budget, which would kind of, I don't know, build a hospital every year or pay for a lot of dietitians, but would do some good. Now, this is why it all matters. There are actually over 1 million people in England alone with a raised hemoglobin A1C of over 58. So that's more than a third of everybody with diabetes in England. We're doing a rubbish job. That's poor control. What we're doing is not working on a national basis. And it really, really matters, because for every year that you have a hemoglobin A1C of greater than 58, you are losing a third of your life expectancy. Now, how serious is that? People like Dan, he's only 40, and he had hemoglobin A1C of over 90. So what is that doing to his life expectancy? And these people die of cardiovascular disease. You know, I've been signing death certificates. This is why I'm so passionate. It really, really matters massively. So having sugary blood, I keep mentioning the word sugar quite a lot. Do you notice that? Having sugary blood seems to be linked to increased mortality, and it's actually aging. Think of it like that. So, with patients, what I'm doing, the first thing is a high blood sugar. I try not to see my patients as problems. It's not nice to see somebody as a problem. So please think of it as a puzzle to be solved with the patient. Rather than lecturing them, see this as a puzzle that you look at together. In 95% of cases, a high blood sugar is something you ate. It's not a mystery. It's not a mystery. Most people know what they ate, and that puts up your blood sugar. Now, we've got to be fair. Some medications, prednisolone, steroids, puts up blood sugar. Stress can put up blood sugar. COVID can put up blood sugar. But really, 95% of those high blood sugars is stuff you've eaten recently. So it's not so difficult to help patients know where the sugar came from. So that's what I'm asking patients. Jen has taught me that questions are more powerful than statements. So I try and ask patients, well, your blood's pretty sugary. I wonder where it came from. What do you think? So I try asking, where did the sugar come from in your diet? And there is one thing that I think so many people don't realize, and that is that starch is soon to be sugar. It's the glucose molecules holding hands. And most of you will be familiar with my teaspoon of sugar equivalent charts, where we're looking at the likely effect of blood sugar of portions of food. So 150 grams of boiled rice is approximately equal to 10 teaspoons of sugar in your diet. So maybe eat something else. Similar with chips and pasta, that kind of thing. Look at the bottom of the chart. Things like eggs, meat, oily fish, green veg, mushrooms, hardly put up your blood sugar at all. And this is the basis of the low carb diet that we've been doing with my patients. It kind of is so logical. It doesn't put up your blood sugar. That's a good idea. Hooray for the PHC. So all my infographics, just Google PHC, Unwin and sugar. There are 7 infographics. They're in maybe 12 or even 14 languages now. They've been downloaded millions of times. They're free. Use them. This is the low carb diet that we use at Norwood Avenue. We've used for years. It's also available on the PHC website. Basically, we're saying turn the white stuff green. So instead of bread, have loads of green stuff. Base your meals on healthy protein. Now, there are 2 problems with low carb, and that is, well, what do you replace the carb with, and is it safe? So one question is increasing dietary fat. Should we worry about that? Nina thinks we probably shouldn't. She may be right. She may be right. The other thing is you could increase dietary protein. So you've only got 3 macronutrients, so something's going to go up. And there's been a bit of concern about renal function if you have too much protein. So what we did, the thing is, if you don't know, is collect data. And actually data makes clinicians safer. So I've been attacked many times, and what makes us safer is collect data from your patients, and then I actually know what happens. So here's what happens. So this is published data from last year, and we can see what happened there to 143 patients at Norwood Avenue who were on the low carb diet for an average of 30 months. They're 61 years old. They start weighing just under 100 kilos, so they're quite heavy people. Look at the hemoglobin A1C as the baseline there, 65. So we're not cherry picking easy cases. We love the cases with the dreadful blood sugars because I get to do the most good. And then look what happens to them afterwards. The average hemoglobin A1C after low carb, after 2.5 years, so it is sustainable, comes down to 47. So diabetes is above 48. So at 47, more than half of the patients are getting a blood sugar in the non-diabetic range. The next 3 in grey are what happens to renal function. That's creatinine, EGFR, or urinary ACR. Renal function at Norwood Avenue does the opposite of what you would expect. So these are older people with diabetes. So age and diabetes is really bad for your kidneys. The renal function should deteriorate in 2.5 years. It actually did the opposite. And that was the purpose of this paper that I wrote. It did the opposite. Renal function improved. So hey, they're having protein, but looks like it's okay for my patients at Norwood Avenue. Okay, we heard so much from Nina about the cholesterol debate. And, actually, Let's look at what happened to the patients at Norwood Avenue who went low carb. So the total cholesterol improved. If it matters, I don't know, but it does actually improve. So I don't even have to argue about that because it improves at Norwood Avenue. The HDL cholesterol, the protective cholesterol, goes up. So that's kind of handy because that's protective. The triglyceride goes down by a third. By a third. So really one of the things I'd say, if you see a high triglyceride, low carb really, really works. And I notice it's now in the American guidelines that low carb works for a high triglyceride. That went in last year. And then look at the blood pressures there. The blood pressure's improving as well. This isn't just about diabetes. It's kind of a healthy diet because I'm so interested, what isn't, so skin's improving, blood pressure's improving, I find mood improves, lipid profiles improve. It's really interesting and very exciting for somebody in general practice like me. Back to Dan again, just illustrating. So what you're seeing on this slide is the hemoglobin A1C at the top, but his blood pressure in the one below. So he presented when he was sugary, his blood pressure was 160 over 95. That's high. And it was 160 over 95 on the highest dose of an ACE inhibitor. So it was high despite all the drugs I'd given him. He was on the maximum dose. And look, he's come off the ACE inhibitor now and his blood pressure is normal. Again, I hadn't seen that kind of thing in clinical practice. And we find that for people who go low carb, I end up stopping their drugs for high blood pressure in 20%. So we're making another saving on the drugs for high blood pressure as well, because for 20% of them, I have to stop the drugs for high blood pressure because they feel dizzy when they stand up because their blood pressure is so much better. And we published that as well. So that's a pie chart showing the deprescribing, all the drugs we were stopping. And there's the average improvements in systolic blood pressure and diastolic blood pressure. And the point is, those improvements, that's understating it, isn't it? Because I stopped all those drugs. So you'd have to compensate and say, well, I wonder what would have happened if you hadn't stopped the drugs. And it would have been about 15. So I got together, that paper was written with a professor of cardiology, Professor Brady at Glasgow University. What's really great is the low carb publications, because of the backing of people like you, the attention scores are sky high. So the little red thing there in the circle, that's the altmetric score. The average score of a paper is perhaps 25. Our little humble low carb thing, 1,500, that's sky high. And so we haven't been silenced actually because of Twitter, because of social media picking up, and the journals are very sensitive to their scores. So I find now when I want to publish a paper, they're writing to me every day saying, have you got another paper? Have you got another paper? Please give us your next paper. So that BP paper was the 4th most popular paper ever published by that international journal. You know, and it's just my little old data from Norwood Avenue. So I'm inexorably hopeful. I'm always trying to be hopeful, and I think that is hopeful. And, you know, we've got a few papers now with a score of over 1,000. So this is somebody who, that's Remission. Hemoglobin A1C below 48 for years. And while I'm talking about remission, I should say, because this is kind of an update too, we now have an international consensus of what do we mean by diabetes remission. So we don't have to discuss that anymore. It is a hemoglobin A1C of less than 48, sustained for 3 months, not using drugs for diabetes, including metformin. And lucky for me, that's the definition I've used from the very beginning. But really, you know, there are different ways to achieve type 2 diabetes remission. That's one thing. The second thing is maintenance. I think maintenance is so interesting. How do you do that in clinical practice? And the direct study have come into this. If we look, the direct studies, the shakes, thing. Roy Taylor, a good friend of mine, and they got some really good results. So at 1 year, they got 46% type 2 diabetes remission, 68 cases. But at 2 years, it was down to 36%. So you're seeing they're having the problem, which is faced by all clinicians, of all sorts of things work, but how do we get it to last? That matters. If you have remission the last 3 months, you haven't really scored the goal. We need something that lasts. And I just point out, you see, that at Norwood Avenue, we're at 2.5 years. So although it's real world data, but it's worth, if it can work, it's proof of concept. We know it works. So you have to drill down into, well, what is it that we do at Norwood Avenue that you could learn from and do in your own practices? So here's a case to illustrate there. This is another patient, hemoglobin A1C sky high at 100. Low carb success, hooray, look at that. Went down to 48, sustained for a while. But now look, oh dear, 82. 82. So what we're going to do? And clinicians all over face that because they're, oh, it's gone up. What shall we do now? So do you remember Mrs. Jones? I don't know whether some of you remember Mrs. Jones because we've done role plays before. So we're going to introduce, Mrs. Jones has waited so patiently in the waiting room all this time. How long does she have to wait for Dr. Unwin? But never mind, he's here now. So we're going to interview Mrs. Jones and take her through her results. Come in, Mrs. Jones, come in.
Thank you.
Well, you see on the chart there your hemoglobin A1C, the sugariness in your blood. I'm sorry to say it's gone very high.
Oh dear.
Yeah. Well, I'm disappointed. I know you wanted to try that low carb thing, and it did seem to work for a while. But diabetes, it gets worse over time, and yours has got worse. And that high hemoglobin A1C just isn't safe. So I think okay, it worked, but that diet isn't working now. You'll have to agree the results are very disappointing. And poor control of diabetes is linked to cardiovascular disease, and death, and ulcers, and blindness, and kidney failure. So, I really think that we need to start drugs and start them today. So I'm going to put you on metformin. We'll start on a low dose because if you use a high dose, it can give you diarrhea. Okay, so we will start that low dose, and I've done the prescription in advance for you, so it's waiting for you at the pharmacy. Okay, goodbye. Maybe I should do that again. I don't know. Maybe I should do that again.
Have another go.
Let's try again. Okay, Mrs. Jones.
Hello, doctor.
In you come. So you can see there the hemoglobin A1C. As I've said to you before, that's how sugary your blood seems to have been in the preceding 3 months. And it's gone up. So I'm just interested, do you know why it's gone up?
Christmas.
Christmas?
Yeah.
Okay, so...
I was doing so well.
You were?
As you know.
Yes.
I was so pleased with myself. And then I had all the family coming and I had to buy things in for them and I was cooking things and I had some Christmas cake. I'd always used to love Christmas. I made a Christmas cake because everyone was coming, had some Christmas cake, and then I just lost it.
So is that ongoing now? What are you actually eating now? Yeah, I couldn't.
I've been trying to get back to it, but it's so hard. It's really hard when you slip up and...
Well, I just first of all like to go back to, when you saw me before, how do you feel now compared to then? Do you actually feel...
bad.
I wondered if you might feel
I feel really tired again and I'm so disappointed in myself.
So what was good about before? Help me understand.
I was sleeping well, I was energetic. I just felt great. I was getting on with things. I really enjoyed, being more in control of the food.
Yeah. So, looking at where we are now, we've got a choice. I don't like the blood sugar to be so high. So we have a choice. I could start medication.
I really would rather not.
Okay.
Yeah.
So that leaves you with, do you think you could maybe do what you did last time?
I must be able to, mustn't I? But I have been trying, but it's been really hard to get back on.
How about we focus in? So what would be the one thing you could do that you would make a start that you can promise me you would do?
I really need to just go home and like get back like I did last time, just get everything out of the house that I shouldn't have. I just started buying things again, and I just need to empty the cupboards and the fridge and do a shop and get all the right foods in.
Can you do that? Could you actually put it in the bin? Could you?
Yes.
Or you could
For you, Dr. Unwin,
right, you could find you could find a friend that you don't like very much and give it to them.
Yeah. No, I mean, it belongs in the bin, doesn't it? I know that, really. It's just so hard to stick to it.
The other thing I wanted to ask is, have you gained weight?
I'm pretty sure I have.
Right.
I've been avoiding that issue.
Right. Would you mind if we weighed you today? Because I think getting a baseline, and then when you see me next time, I know you can do it.
Okay.
Right, so we'll get the baseline.
Okay.
How do you feel about booking another blood test, let's say in 6 weeks?
Yeah.
Do you think you could do it?
That's a good idea, because then I'll be motivated.
Yeah, listen, I know you can do it. You will. You'll do it.
I'll do it. I'll do it for you, Dr. Unwin.
Right. So let's see what happened to that patient.
Hooray!
Hooray! And what I'd like to point out is that, as we get older, we learn stuff. So this patient, look, those results are the best she's ever had. So she did it even better. So intelligent people reflect, do things differently, experiment, and do better. And this is a great part of ongoing management of people, helping them learn from their own experience and giving them relevant feedback so they know how they're doing. There is one little thing for the clinicians here. If you have somebody whose hemoglobin A1C goes up, but if they're losing weight and it goes up, that's weird. It's rare but weird, and you must look into it every single time, because it can be a carcinoma ahead of pancreas, or it could be a misdiagnosed type 1 diabetic. So I'll just repeat it. If your hemoglobin A1C goes up, the sugariness goes up, but the weight comes down, in clinical practice that's very odd, and it always needs referring up to be investigated. So this is yet another. I think you've met Chris before. I love Chris. He's one of our longest standing ones. He got published in the BMJ a few years ago, but he's very long lasting. But he's also learned. Look, we call it Carb Creep. And hardly anybody doesn't get Carb Creep, and all of you probably have had it, and you have to learn from that. How did it happen? What would you do differently, and how do you feel? So this idea of maintaining is so, so important. Over to Jen.
Over to me. So this is, I'm coming into shot.
That side, that one.
That one, yeah, thank you. This is a proportion of people have this difficulty, and there's quite a few of you in the audience, I'm sure. This probably would have been, my graph used to look a bit like this as well. And this can be an indication of someone who is struggling with a food addiction problem, because they know what they need to do, and they manage to do it for a while, but then Christmas happens, a holiday happens, something else happens, and whoosh, right back into it. It's there in the background. Sugar. If someone has a food addiction, a sugar addiction problem, they've got that for life. And so the minute they have some of the drug food, they're straight back into it. And this is a very typical pattern. And we've had several patients with this triple, quadruple dip sort of pattern. Oh, look down here. Okay, so we have to ask, don't we, if someone intelligent does something they know is going to harm their health again and again, what that might be about. And in a way, it's a hallmark of addiction, where people are doing things that they know are harming their physical and mental health. And I'm sure as practitioners and ourselves, we've recognised that behaviour in ourselves. So it's important to ask about that. And David does that now. He does sometimes say, if he sees these kinds of patterns, do you think you might be struggling with some addictive relationship to some foods? So, as you know, that's my interest now. And Heidi, who's there, wave Heidi, my woman in Friday. We're doing a lot of work together on this issue of food addiction and how do we help people with that? It's a little bit more complicated than just giving advice, because if giving advice worked, nobody would smoke. We all know smoking's bad for us, so people would just stop. So for those people with an addictive problem, you need to do more than that. So this is our screening tool, which we've developed from the criteria for substance use disorder, WHO in their classification of diseases. It has these 6 components: a compulsion, powerful urges to consume, increased tolerance and needing more and more, ignoring other activities in life, the volume issue, eating more than you intended, thinking you'll have a couple of biscuits, always eating the whole packet, experiencing withdrawal symptoms when you try and stop, shakiness, headaches, cravings, etc. And then this issue of continuing to use despite harm. So we have a screening tool with questions based on this. And if anyone wants to know more about it, we're going to do a Zoom call with clinicians who might like to use it in their clinic. I don't know if David Cavan is here, but he's been trialing it. He's not here today, but he's been trialing it in his clinic, and we've been using it in our research. And just quickly, for those of you that were here yesterday, you'll have seen this, but we're really excited. We're doing a study with two other teams looking at a group intervention online for people with food addiction. And this is just some of our initial data. It's just the before and after the active intervention. We are going to be following people up for 2 years. And you can see from that we get a really significant improvement on the craved score after the intervention, and also on well-being and other scores. So if anyone wants to know more about that, come and ask me. I won't labour it, because it's not the main topic of this talk, but really it's important for long-term maintenance that those people with this issue that they're identified. So what might be some advice for clinicians? It's advising people to find out which foods they can't moderate. So it's a bit like if you have a problem with alcohol, then you better cut out the alcohol because you can't moderate it. So if you have a problem with sugar, then you need to abstain from sugar. You're never going to moderate it. Clearing out the cupboards, filling the fridge. We're very cued by sight, sounds, smells. It's difficult in the society that we live in to avoid food, but we can make our home spaces safe. And even if other people in the family don't particularly want to join in, we can ask them to put their food out of sight so that we're not cued to see it, and to work with family and friends, and then discuss with patients whether how they want to move towards this avoidance of their drug foods. Bitten and I are more of a fan of the cold turkey approach because it's quite hard to transition slowly if you're a food addict, because you can't do moderation by definition. So if proper food addicts, cold turkey. People like David, who are kind of Bitten's told him he's a harmful user rather than an addict, then they are able to transition onto a better plan. Okay. This is. Do you want to talk about the gremlin?
I do. So for the past few years, with Jen's help, I'm trying to help my patients understand themselves better, because they're so confused, because they think, I must be so stupid because I keep doing this over and over. Why am I doing it? I must be a mad person. And actually, it's a great relief for many of them to understand there is a reason that they keep going back to bread or potatoes or crisps or whatever it is. I've had a lady, I remember one lady who weighed over 20 stone for 25 years. And one day I said, you've been on so many diets, I just wonder if you could be addicted to some foods. And she said, I'm going to tell you it's bread. And she burst into tears. She said, in all those years, I've never told anybody that it's bread because it sounds so stupid. I'm really embarrassed to tell you this. But she was also crying because of relief, because she understood herself for the first time. She wasn't a mad person, she was an addicted person. Such a relief for her to know that there is support and we can help. So one of the things I do, I try and get the person to understand that they have on one side their intellectual, clever self, and on the other side there's a little goblin like this fellow whispering in your ear. And they whisper stuff like, go on, you can start the diet on Monday.
You can have a little bit.
Yeah, go on, you can have a little bit.
It's your birthday. You've worked so hard.
Yes.
Everyone else is having some.
Okay, that's the goblin. And that's exactly the kind of thing, thank you, that's exactly the kind of thing that the goblin whispers. And all of us, or many of the people in this room, have had goblins whisper in their ear, it's not Monday, go on. But sometimes Monday never comes. Some people go on and they get bigger and bigger. But it helps them to understand how are you going to you are an intelligent, resourceful person. How are you going to use that intelligence against the goblin? And that is the beginning to reflect on what works, and it gives them a model. Bitten has her red dog and blue dog. There are different, but it's a similar thing that we're all a bit like two people in one, the good person and the bad person. Oh, Jen's book. So listen, this is Jen's Lockdown Baby, the book. The important thing is it's not for profit, so the profits all go to this wonderful charity, the PHC. And it's a very practical guide. Jen's written the book she wishes she'd read when she was 16. So she's tried to put together a small practical guide, and the profit goes to the PHC. And guess what? There are loads of copies here today, and they're discounted at only £10 as your perfect take-home thing from the conference, and they're for sale from lunchtime. You see, Jen can't bear to blow her own trumpet, so I said I'd do all that. So please get Jen's book. We are.
And we've just published a journal, a 100-day journal. It's not here, unfortunately, because it sold out yesterday, but you can get it on Amazon. So if you want it for patients or for yourselves, if you want to really keep track of your intention to stick to the plan, there's a 100-day journal, and it's got lots of different kind of advice in it. So
we're still thinking about maintenance and how to help people long term. It also has to be affordable maintenance, in my case in the National Health Service. So we find that group work is great, and it isn't just affordable. You get an extra wonderful dynamic from patient experts like Dan and Chris, where people help each other. So it's affordable, it's sustainable. And we've been doing that for 9 years, right from the very beginning. We've been running groups, and of course now COVID, they've all gone to Zoom. But that's the thing that, what we actually do at Norwood Avenue is, so every single person with type 2 diabetes gets a code. We're doing the Zoom on Wednesday night after work if you want to join. So it's a really efficient way to connect your practice with people who might be interested. Just some stuff about running groups very quickly. Jen has taught me this. Thank you, Jen. It takes two people to run a group. So you have to have one person that's like chatting and the other one's watching in case somebody is distressed, or in my case talking too long, and then Jen will tell me to shut up. And the thing is, the PHC ambassadors are quite happy to help. They're a free pair of hands in a practice. They will help you run groups. So think about that, because that's really saving money, because you get somebody helping you for free. One of the things that Jen taught me is again, this idea that questions are more powerful than statements. Questions make you think. So when a member of the group asks a question, no matter how, it's really difficult as a doctor, because I think I know all the answers, so I'm always dying to tell you the answer. Like, just give up the sugar. But actually, if I can get people like Chris or Dan, so get the members of the group to answer the questions. So you say, before I say anything, let's go around the group, what do you think? And that gets your group going and functioning well. You've got two decisions. Will you have an agreed curriculum to run the group? So at the beginning we had an agreed curriculum. Or do you have it person-centered, where you just answer questions? You can do it either way, or a mixture. The other thing is, are you going to have an agreed number of sessions and then start again? Or like us, it's just open-ended, rolling on and on and on for 9 years. So there's different models. The Freestyle Libre. This is a thing of hope. Watch it. It's really, really interesting. So the Freestyle Libre is, you have a thing on your arm and it tells your phone what your blood sugar is 24/7. That's powerful feedback. So here we have a case, somebody with very poorly controlled type 2 diabetes, blood sugar of 120 millimoles per mole. That's really, really, really high. And look, that diabetic control went off year on year, going up and up and up. And I kept saying, I wonder where the sugar comes from. And the patient had no idea. So against the guidelines, I prescribed some Freestyle Libre for a month. And very quickly, that person, turned out they were drinking pints and pints of milk. Every 100 mils of milk has got a teaspoon of sugar in it. On top of that, there was fruit juice and other things. And look how rapidly, this was a man, he learnt. So the feedback was specific, rapid. He learned and changed his behaviour. And do watch the type 2 diabetes and Freestyle Libre thing. At the moment, doctors are not allowed to prescribe because it's against the guidelines. But do remember, they are just guidelines, you know. And I'm a healthcare professional, and if I'm really thinking about the best interests of my patients, I wonder if I'm going to end up in jail because I've done this. I wonder. So I'm starting to do it, and let's see. PHC again. So one of the things with PHC is to produce useful resources for all of you. So we've got a resource page. You've got low carb booklets. You've got a nurse and doctor protocol. You've got the sugar infographics in 12 or 14 languages. There's the wonderful Freshwell app, if you want an app. There's loads of stuff there. So that this is the new website, and I think it's brilliant.
And there's also food addiction resources pages. There's a few pages on food addiction for clinicians and families and patients themselves.
Good point. Hey, the free gift. See, I love all you people. And last year, I don't know whether you remember, I gave you a free gift. So there's one this year as well, because I'm so happy to be here. So here's your free gift. It's another one of my infographics. No, it's not been seen until today. You're the first people to see it. So here again, you've got your white boiled rice there, 10 teaspoons of sugar. But actually, if you compare that, so I'm often asked about vegetarian. If you actually compare white rice, and maybe what if you ate kidney beans or lentils or broad beans, you can see there going down that actually legumes have about a quarter of the effect on blood sugar of rice. So that you could do some good like that. I'd also like to draw out the difference between wheat flour and gram flour. So gram flour is something used in India traditionally to make chapatis, things like this. It's chickpea flour. So it's a legume flour. It's got more protein, less sugar. So the gram flour per 100 grams was like 2 teaspoons of sugar. This is worked out from the glycemic load. But wheat flour is 19.4 teaspoons of sugar. So why don't we use gram flour more often? And that could be something of an international thing to think about. So that's your free gift. Now, I realised that if that had been my free gift, I'd be a bit disappointed. If that was Christmas and you gave me that, I'd be a bit disappointed. So what I've actually done, I've had a huge box printed, because I know you want to take real stuff home. And so probably what I'm going to do, I hope you're going to go to the room. I think we're selling books at lunchtime. So I will distribute these all over the room. Just take them. Please take them. And there's that one and then something else on the other side. So it's an actual proper free gift. Right. And there's some of the references of the papers that Jen and I have published. There's one paper I'd like to highlight, which is number 13, Dietary Strategies for Remission of Type 2 Diabetes and Narrative Review. That is historic, that paper. What happened was the British Dietetics Association sent for Jen and I and Asim and other clinicians to London. And we have published a joint review with the British Dietetics Association, published in their own journal, concluding that low carb is safe, effective, and that type 2 diabetes is entirely desirable. So what we've got now is agreement at a very high level with the British Dietetics Association. So any of you that have any kind of problem where a healthcare professional is saying that low carb is not safe in type 2 diabetes, you could just, that's open access, you can print that off, because it's a total agreement between very senior dietitians, very senior clinicians, and published in the BDA's own journal. So that's my final word on that. That's a really important development. I never thought I'd live to see that day. Very good. So I think we've finished. Thank you so much.